So please help me here. We're going to be talking about restless leg syndrome, and that's not one that people talk about a lot. So I wonder how many people here know what it is. Is anybody here? How many people have restless legs that are here? Ah, you're my people, okay. How many people have family members with it? All right. Yeah, if you have it, you know it runs in families, don't you? So if it has a strong genetic component. In fact, there are only a couple of diseases in neurology or in sleep medicine that we've proven has a genetic component. Restless legs is one of them. Narcolepsy, less so, but restless legs has clearly got a nice, strong genetic component. And we even know the primary genes involved in it. Well, those of you who haven't seen restless legs, what do you think it's like? Does anybody want to tell me the patients who have it, can you tell me what it's like? Anybody want to be bold and tell me? All right, some people say it's dancing around all the time. But it's really not that, is it? It's really a difficulty staying still. And at night, just when you want to go to sleep, what happens to you? Your legs start moving, right? And you can't stop them always. And that can happen in the daytime too, if you're sitting for a long time. So this is a disease which really robs you from the ability to sit like you are now for any length of time in the afternoon or evening. It's time of day. Now, many people say, well, it's a minor disease, doesn't really matter. Those of you who have it, I hope will tell me that's not true. It's really a bothersome disease. How many people have said they have it here? Does it bother you very much? Does it make your life difficult? Yeah, it can, can't it? It can make it hard to go to meetings and so forth. One patient I know had to get up and paint in order to be able to get through the night. Well, what I'd like to do is, for those of you who don't know what it's like, I'd like to show you just a couple pictures of some people who really have it, a moderate degree and then a severe degree. So you get an idea that this is not a trivial disease. Because many people think restless legs, oh, that's just people who can't sit still. And it's not that. It's much more serious than that. So let me see if I can show you just one picture. And this is going to show you the characteristic, the classic movement that goes in sleep with restless legs. Person goes to sleep and then their legs start moving. So let me show you this if I can. How do I do it? Do it like this. And click on here. And you notice, this is sped up by 5 times. But you notice the type of movements he's doing here. He's moving his leg, his foot clicks up, then he's moving his knee. If you're sleeping next to this man at this point, you're not terribly comfortable, right? And you know, the irony is these people, until about 20 years ago, were doing it every night without any treatment. It's a disease which really disturbs people a lot. And it disturbs their ability to sleep at night, and also their ability to sit still in the day. Let me show you somebody who has it, an example of somebody who has it much more severe, if I can. Well, that's pretty bad, but let's see if I can get the next one. Now I want to make sure I don't get the sound with that. Oh, good. This man, this is again sped up by 5 times. I want you to think about this. Suppose you're a bed partner. Think about this for a moment. Suppose you had this for 5, 10 years, and you went to your doctor, and you know, even after doing all this at night, if you watch him, he does some pretty dramatic things. Why is he doing such dramatic things? Because his legs feel just rotten. They hurt, or they feel like they have an urge to move. He just can't get the sensations quiet. He's going to rub and massage. I think he puts a pillow between them. He kicks the leg out. He's doing anything he can to calm down the sensations, and he can't do it. And as I said, till 20 years ago, 25 years ago actually, these patients had nothing they could do. They just had to suffer with it every night for many nights. Now, the paradox is, let's make you all doctors here, okay? I'm going to make you expert neurologists. We'll give you a diploma, all right? This patient now comes into your office and he says, I slept like this all night. And maybe I got 3 or 4 hours sleep. And you look at him and he says, well, are you tired? He says, no, I'm not tired. And his eyes are open. Well, are you sleepy? I'm a little fatigued, but I don't feel like I'm falling asleep. And one of the ironies of this condition is that it leaves people fatigued but not sleepy. It leaves them maybe a little bit tired. But they'll sit there in your office now telling you they're wide awake. Now, what's your first reaction to that? Not only that, if you ask him, what are these sensations like? He's going to say, well, they're sort of like things crawling in my veins. One patient said it was Pepsi-Cola in his veins, or Coca-Cola in the veins. It's ants crawling inside of me. In fact, it got confused with a condition where people do think they're infested with ants, a psychiatric condition. But it's not that. So if the patient, now you're the doctor and the patient's telling you that, where are you going to refer this patient? You're going to give the patient medicine? No. What are you going to do? Come on, you're a smart neurologist. Well, you're going to refer him to a psychiatrist, right? Get him out of your office as fast as you can, right? You don't want this guy around. He's clearly crazy. Nobody can go through that at night and sit there and tell you that. But in fact, ARLIS patients do. You know, it did happen to them. Many of them got referred to psychiatrists. There's a very nice case that I know the man. He got referred to a psychiatrist, and it was a psychoanalyst. Does anybody remember psychoanalysis? Good, some people remember it. It's a wonderful treatment, and if you remember, how many people saw The Sopranos? Anybody know? I guess, okay, in The Sopranos, there's this wonderful psychoanalyst dilemma that goes on. It's part of the whole plot of that movie, that series. The interesting thing is that this man went to a psychoanalyst and he spent a few sessions with him. You know, you go once a week, twice, 3 times a week for an hour, and you sit there and you share things, and the psychoanalyst expects you to do the talking and do the work, and he sort of writes notes, but he gives interpretations. So finally he said, you know, I think your problem is that you're really trying to kick your mother out of bed. And then he said, no, now I think about it, maybe you're trying to kick your father out, and then you'll have your mother with you. It seriously happened. It's hard to believe that that's what he said to a restless legs patient. And that his treatment was to resolve his Oedipal complex. That was the treatment. That's what he needed to do. And if he came to see the psychoanalyst long enough, he might get resolution. You know, it may take a couple of years at 3 times a week, but it would work. It's a neurological disease. It's not a psychoanalytic disease. And it's a really fundamental neurological disease. And when we started working on this, and I was one of the groups that sort of started going, and I don't want to keep you long, I'm the last speaker, so I'll try and push through to the end. When we started on this, there wasn't anybody who could really buy into it as understanding the neurology. And so we started asking questions about the disease. One of the questions we asked is, who has it? And so we did a really nice survey. And I can show you the results, maybe I can show you the results of the survey. So how many people have this disease? And we were told it was almost nobody. And then we were told it's a rare disease, about a few people have it. And we did the survey, we found out that 5 to 7% of the population have this problem. 1% have it as bad as these people I've been showing you. That's a lot of people. 1% of a million people is a lot, right? So all these people were out there. They were writing notes to the paper. I saw one in the Washington Post where the doctor said, answering the note to the patient, saying, well, there's not much you can do about your condition. Maybe you can get some really heavy opioids or something but he didn't want to give, so there was nothing really to do. And of course now we know that's not the case. So we started asking the question, what is critical about it? And first we asked who had it. And to do that, let's see if I can show this. Oh, how do I do it? No, that's what we had already. There we go. This is the article that we finally published on this. And as you can see, it's 2005. It took us about 15 years to figure out even how to do this and then get the data out and publish it. Now, what's interesting about this is I want you to pay attention to this slide. Notice the age issue. Can this show? Does it show in there? No, it doesn't. Oh, well. All right, so if you're looking at the slide, if you could see, it goes up with age. And it really doesn't have a lot of people, 20, it's 1%. It's 0.5% of children. Children have this too. And 0.5%, by the way, is more than have epilepsy. So it's a really relatively common problem for children. And it goes along with attention deficit, by the way. So the people with attention deficit and restless legs have go together, and I'm going to come back to why that happens if we can stay together. If all of you can stay with me, stay up on this. All right. There's an orange line for men, and they go up a little bit with age, up to 3%. But look what happens to women. After age 30, they really start climbing. And they get really profound. Now, why do women get more, but only after age 30? Now here, I want you to become a scientist, or maybe a clinician too. What happens to women after age like 25 that never happens to a man? They have children, go to the head of the class, absolutely. So, of course, it took us 3 or 4 years to come to the same answer. It's an obvious answer, but we didn't see it. And then finally somebody said, well, does that mean if they didn't have children, they'd be like men? And that's true. In other words, pregnancy accounts for why women have it more. But it's not when they get pregnant, though they are more likely to have this. So first of all, they're more likely to have it when they get pregnant. Second, if they get pregnant, they're more likely to have it 10 or 20 years later. But at least it told us that pregnancy was an issue. And then the other group that we found out that was important were people who had iron deficiency anemia. And so we started thinking about that. If pregnancy is happening, what's the biggest fight women have nutritionally with pregnancy? You probably know. B12 and iron. Absolutely. So now notice, iron deficiency anemia, iron in pregnancy. There was an iron in end-stage renal disease where this happens. There's a gastric surgery people do for weight, and they tend to get restless legs, a lot of them. And again, they have an iron compromise plus a vitamin B12. So we were pretty stupid, but we said maybe we should look at iron in these patients. And when we did, you can measure iron, in the periphery, but this is a brain disease. It's not going to be because your muscles are weak. It's a brain disease. So we want to know if iron is low in the brain. And fortunately, we now have the techniques to measure that. We have these marvelous, any of you been in an MRI? You have? Anybody else? These are marvelous little tubes. They hook you into, some people, I know a very dear person of mine, can't stand them. They get absolutely crazy when they get near them. If you're claustrophobic, don't get an MRI, or they're really hard to take. But anyway, they put your head in this little tube, and magnetic currents go around it, and we can look at the brain, and we can measure iron in it. And when we did, we found something really interesting. We found, let me see if I can show that. We found that on the right, the white things here, if you can see them there, the big white spots, that represents iron in a normal person. On the left is the RLS patient. Now, you've just all become experts in reading MRI, you notice. You're not only great clinicians, but you're now also experts in reading MRI. Notice, there's no iron. The iron's missing in the major dopamine-producing areas of the brain. It's totally devoid. And this was just an eye-opener to us. So we started exploring this. And if iron is gone to people, what do you want to do to correct it? An obvious thing would be, what? Take more iron. Yes, another head of the class here. Boy, you guys are bright students here. I like this. How can you get iron? One way is by a pill. Have any of you taken an iron pill ever? Yeah. Are they fun and they make you feel good? No. They're pretty miserable, aren't they? But you can take it. That's one way. And it does help a lot of restless legs patients, particularly if your peripheral iron's on the low level. But what's the other way you can get iron? Well, berries, that's true. You can get it by good diet, but also you can get it by IV. It's a drug that can be given to you. You can go in, have it given to you in a few minutes, and you can correct to some extent the iron problem. So this started us thinking about using iron as a treatment. Now, we also, at the same time, started developing medications, and the medication that people use most were the dopamine medicines. I have a personal confession here. I was one of the people that helped get the dopamine medicines going, and they really are immediately effective for this disease. It's the same medicine you use for Parkinson's disease. The problem is that restless legs is not Parkinson's disease. It's totally different. Parkinson's disease occurs in men, restless legs occurs more in women. It's just a totally different disease. And if you keep taking dopamine agents for a long time, it makes the disease worse. So what we did initially led to taking too much of a drug, and we really are working very hard now to tell people, be careful of dopamine treatment for restless legs. Use it sparingly and watch that it isn't making your condition worse. It may be gradually making it worse. Our view is that there's a limited time you can take it in a limited dose, and eventually, for most people, you will need to switch to a different medicine. And we do have better medicines now. We have a couple very good medicines, one of which is an alpha-2 delta ligand, which is a fancy name. Boy, that's a fancy name, isn't it? It's called gabapentin or pregabalin, or the other one that's famous in the United States is Horizon, which is gabapentin N-acarbonyl. And these medicines are really effective without long-term effects. So they're ones to think about. But the exciting thing is, let's get back to what I said. The exciting thing is we can give iron. And if we give iron in some patients, and here are the data. Now, I know slides are hard. It's a pain to show slides, isn't it? So stay with me just a little bit on this slide. And I guarantee it's almost 2:30, and I'm supposed to be done by then, and you're supposed to ask me questions. So let's see if I can end here without losing you. You see that green line, and on the right is a score. Now that score relates to a severity of the syndrome. 30 is really bad. That's people who are just jumping all the time. 10 is almost nothing. If you're below 10, we call you're in remission. Now notice what happens with the green line. It's right up at 25, which is very severe. And then we gave them IV iron there. We gave them 1,000 milligrams of a compound called ferrochrome oxymaltose. And we just followed them. One treatment. No continued daily medicine or anything. And just look what happens to the treatment, the symptoms. They gradually decrease. Not immediately. It takes a while. IV iron doesn't work immediately because it's changing metabolism. But it does eventually work, and that green line comes down. Now the red line you see there are the group that, this was a placebo-controlled trial. The red line, the people had placebo. And so we gave these people treatment also. And it worked on them just the same way effectively, almost as good. So the problem with iron treatment is only about half our patients respond. but half show a good response, and a third show they no need, at 6 months later, they have not needed any other treatment. So we're working now to develop these iron treatments better, and there is hope that we'll have better iron treatments in the future. But right now we recommend that people, at least if they have restless legs, if you know anybody who has restless legs, let's try and correct the iron problem. Now, you're a good scientist, aren't you? There's a low iron in the brain. We've given you IV iron and we've corrected it. What haven't we corrected? Why the brain iron is low. We haven't changed that. And so it may come back, particularly if you're bleeding a lot as a woman, if you're losing a lot of iron for other reasons. So you might have to have repeat treatment. But at least we have the option of giving you a treatment that actually corrects the underlying biology. This has been an exciting trip for us in restless legs, because we know patients now who have good treatment that they didn't have 25 years ago, and we want to offer that to people. And this is an example of how sleep medicine has progressed over the last quarter century. So we offer good treatments to people. So I want to thank you for staying with me. I'll answer any questions you have.